You're tuned in to RX Radio.
What is the worst injury you have ever trained through?
I have two different answers for that. The number one was actually the worst injury, but I didn't like train through it in the sense I think you're saying. I completely snapped my ulna on my right arm, like a full break. And then I just did like left arm shit and leg press for like 3 months. So that was, yeah.
What happened? Like, did it grow back? Like,
So it was like a complete fracture. It actually, I didn't even need to get surgery, need to get it set because the radius didn't break. So it was relatively aligned. So I was just in like this fucking full arm cast from the wrist all the way up to the shoulder for like 6 fucking weeks. I was just like this. So I was just doing bicep curls and like leg press and shit on the other side.
This happened in Pennsylvania, undoubtedly.
Oh yeah. Yeah.
Did you go to a vet by chance?
I went to the hospital. I think the official diagnosis was toughen up, kid.
That's Pennsylvania diagnosis. Unfortunately, they're still giving out that diagnosis in Pennsylvania. I'm sure medicine elsewhere has come a long way. Yeah. That's wild. Okay. All right. Yeah. That counts-ish. What's the second one?
Yeah. So that was a pretty gnarly one. The second one was actually very recently. I think it was winter. It would have been January of 23. So a bit over a year ago. I herniated the fuck out of my L5 disc. I was doing split jerks out of a squat rack. So I was bringing the bar down to the back of my shoulders in between so I could re-rack it and do the next rep so I didn't have to drop it, get it up, all that shit. One rep, I brought it down. I just felt like something move in my low back. And then instantly the whole left side of my low back just tightened up. I'm like, fuck, I just herniated a disc. Like instantly I knew it. So that really sucked. And ever since then, like there's a portion of every day that I can't feel my left foot every single day.
Oh,
yeah. I didn't stop training for that one though. So I think that's more in the sense of like training through an injury. I think that's probably what you're talking about is that like I had the injury. I probably took a day off and I'm like, all right, what do I need to do to continue to be functional enough to get some sort of exercise in so I'm not just on my ass for the next 6, 8, 12 weeks.
Yeah, I feel like I could translate that for the lay person. And what you actually said to yourself was, how can I continue to make poor decisions?
Yeah, no, that's that's my driving force every single day.
Oh, that's nuts. Okay, so I tore my quad on the second rep of a 300 kilo back squat.
Oof.
And then I did a third rep. So that was like acutely training through an injury where I'm like, yeah, that's torn.
So in Pennsylvania, when they say toughen up, kid, that's what they mean.
Okay, great. I think I have Pennsylvania citizenship now. Tremendous. That's tough. I mean, I haven't had an ACL in my left knee since I don't know how long. So I don't know. I mean, if that counts. And because I think the takeaway here is, there's obviously gradations to injury, which if we're going to maybe advise on a checklist, because you brought up something interesting that you're at a point, and I hate when people cite the Dunning-Kruger effect, but like, so much about the body that fuck a disc didn't mean don't stop.
Right.
Or sorry, it didn't mean stop, right? But I think the dangerous part of that Dunning-Kruger effect exists when someone has that base level knowledge to maybe be able to go like, something moved, foot go tingly, oh my God, it's a disc. And then they stop. So I think like if we're looking at underlying principles of like, okay, we all have a little something going on or a lot something going on. What is a triage troubleshoot checklist for training around an injury? And maybe there's a disclaimer to be like, hey, after I tore my quad or after you broke your ulna or after I tore my pec, there was no training happening of that particular region. So like, to quote Kyle McKee, owner of Capital Strength, this is not medical advice. But it's like, all right, let's work within reasonable parameters here of a reasonable person. We both operate in the training around injury space professionally.
Yes, we do.
So what is the, like, where do you start with maybe advising someone? You obviously have an internal dialogue of like, fuck the disc, back crack, okay, shit, problem. And you started troubleshooting right away. How do you advise someone to build their own process?
Yeah, that's a really good question. And I think that a lot of people are going to need help informing this, because this all starts with understanding the mechanism of injury for me. And not just the mechanism of injury, but actually the structure or tissue that's injured and what the implications of are that injury. So for me, it's like, we'll take the disc, for example, like understanding, I know the symptoms, the radicular pain, I know the acute symptoms, muscle spasm, that indicate a disc herniation with nerve impingement. And I felt those immediately, and I knew within seconds, like, okay, I know exactly what happened here. I don't need to fucking keep testing. I don't need to go get an MRI. Like, I know exactly what happened here. The average person is not going to know that. So you're going to need to take a second. And I think something important to note with this too is that with acute injury, the symptoms aren't necessarily going to be indicative of the structure that's injured right away, right? Because I've worked with so many people that, just exactly like you said, I'll have an injury in a workout and it sucks, but it feels okay, and I'll just kind of keep going because you have, adrenaline, you have the endorphins, like, you're warm in the moment. You don't necessarily know the full magnitude of the injury in the moment. So it's like, I've had so many people rolling an ankle is another good example. If you have someone that rolls an ankle, they'll probably be fine until they sit down for a couple hours. And then a couple hours later, it's going to swell up. It's going to balloon up. Every muscle from like their TFL down is going to fucking spasm. And they're going to feel way different a few hours after that injury, once they cool down, than they did in the moment when they injured it. So I think maybe the first thing for someone that doesn't have a background knowledge of mechanism of injury, you don't have a good understanding of differential diagnosis, is just give it a minute. Like, if you do something and it feels fucked up and you're concerned about your future of training because of that injury, give it a minute. Like, there's no one session is really going to change the trajectory for the better in your career, but it can change it for the worse, right? If you push through something, like, I'm sure your squats probably haven't been the same since that quad injury. So, and I mean, it makes a great fucking story. So you have that at least. But if training is important to you and you want to continue to train, it's not worth pushing through something that might be an injury that should be dealt with just to finish the session, because you're not going to have a true read on what you're feeling, what's going on, what the repercussions of that acute injury are until hours to days later. So number one thing is just chill out and let it settle in and see what symptoms you do have. And a lot of people that have been training for a long period of time, they know their body well enough, especially if we're talking athletes at the professional or a higher level of athlete, or people that have a higher training age. They understand what they can train through and what they can't. And that's the way that I'll verbalize this, is the difference between pain and discomfort. Pain is something that there's not really going to be any positive adaptation to be had from pushing through it. And there could be negative adaptations, like a torn quad. If I were to continue to squat on that, it's not going to make it better. It's actually going to make it worse. So that's pain from that definition. Discomfort is like a 5x5 of squats at 70% for someone that's perfectly healthy. Like, it's probably going to suck. You're going to get tired. Your muscles are going to do things. Maybe you'll have some spasms or twitches or whatever, but you get through the workout and there's positive adaptation to be had from pushing yourself through that discomfort. So being able to differentiate those two things, I think, is probably one of the most helpful things that you can do if you want to continue to train through any sort of, whether it's acute injury or whether it's chronic, long-standing things, because that's the conversation shifts a little bit when we get to chronic things. But that's where I would start, is that first off, acute injury, if you feel something within a workout, chill out. Like, there's nothing to be lost by not finishing that session, or kind of to the theme of where this conversation I'm sure will go, is that just do something else. Like, okay, I fucked up my disc, but like, I mean, I was done for the day. I was fucking pissed. But if I wanted to continue to train, I'm going to do something where maybe I'm more externally supported. I don't have to brace my core. It's probably not going to be lower body. So I don't know. I'll go do preacher curls for an hour, just until I'm not pissed off anymore and then deal with the rest later. So being able to differentiate that what's going on, what you should and shouldn't push through, and then whether it's seeking out some sort of advice, someone like you or myself or whoever you have that can advise you on this sort of thing, to get some sort of interpretation of the symptoms that are presenting after it has mellowed out, like after a 24, 48, 72 hour period. So you can start to get an understanding of, okay, this injury is going to affect me like a quad tear. That's going to affect you for minimum 8 weeks of that tissue healing period time. So it's like, we're not going to do quad exercises for the amount of time it takes for that quad to get back to a structural integrity that permits us to load it in a way where we can now adapt in a positive way if we were to do that.
Yeah, I think you bring up a super interesting about time. And I think I've had people, you don't get away with it, right? Like, because we're talking about injuries at the gym, which, are one thing. I've had people who've like come in to train and gotten in car accidents.
Ooh, that's different. Yeah.
But it's like, so if at any point you're like, wow, I got so lucky, take an extra 2 days. Right. Or I have people who, that can currently weight train and, fight mixed martial arts or UFC or jiu-jitsu. And it's like, man, craziest thing. And I ended up, my shoulder was like behind my whatever. And I was like, shoulders don't go there. Let's, maybe audible lower body day, stay away from that shoulder entirely. But really, and if you're a coach, instilling this and being like, I'm going to check in on you daily for the next 3 to 4 days, right? Just because I got in a car accident when we were in second year. I was on my bicycle and I got hit by an SUV. Immediately after I got hit by the SUV, I picked up my mountain bike and I threw it at the hood of the car that just hit me. My shoulder was still dislocated when I threw it. I might as well have just thrown my arm at the Suburban.
Yeah.
And I didn't feel shit, but anger. Like, that was all I felt, was like, yeah, you stupid. You couldn't even, And then the next day I went to school. Sure, I talked to you and I talked to a couple of people like, let's get you in an imaging center. And was like kind of thrust into the med legal process. And, after 3 or 4 days later, splitting headache, shoulder couldn't move, hand was going numb. But And the same thing, guys come out of the octagon. It's like, I'm not touching you for a week.
Yeah.
Right. Like, you were just in Francis Ngannou is a problem. Like, that's a car accident of all car accidents. And he was car accidenting your face. So it's like, you can't interpret, it's all noise. There's no data. So I think there's really something to be said about that of like, hey, if you have the wherewithal to have an understanding of like, look, let's really see how the dust settles on this and try and interpret the potential magnitude. Like, if you hear like a little bit of a pop in your back and you have 600 pounds on the bar, let me tell you how this works. Like, little pops at 600 means that you're using the walls to get on the toilet later that day. Right. So, definitely hey, today's training session is not worth it to push it any further, but you have to there's a coefficient of magnitude in there somewhere. Chevy Suburban, right? Even as far as a mid-size, or 600 pounds or, 2 times body weight or something like that. These little things at heavy relative loads can spell disaster. And your body, thank God, does a really good job at keeping you safe from pain. So you can act in the moment to get away from the noxious stimulus. Like, it's super useful. Like, people who get shot, they get stabbed, they don't really feel it. Now, a couple days later, wow, that really hurts. But it's your body's like, how many shots was that? How many does he have in the chain? Like, how many are up the pipe and how many are in the magazine? We're going to deal with the pain when we get away from the flying bullets. Right. And it's like, someone who doesn't feel pain when they get shot knows they need to get away from the gun. Someone who doesn't feel pain when they have a 600-pound deadlift on my back, I heard a noise between, get away from the bullet, dog. That gun is still loaded and there's one ready for you if you decide to go in for another rep, right? Like, that thing will finish the job. So there's something to be said about having a 36,000 foot view of kind of the set and setting of where this thing is happening, because that'll allow you to apply a modicum of critical thinking that will allow you to temper your expectations, right? And then I think moving past that, you let the dust settle. You're now at a point where, for me, an accurate tool, or the tool that I would suggest people look at first and foremost to help establish some sort of framework, pain-free passive range of motion. Right. Yep. That, to me, whether you're going to a therapist or whether you're kind of handling the issue on your own, or whether you're a coach and you're advising someone through this process, whether being co-managed by a clinician or they're trying to do it themselves, that is such a pivotal place to start. How far can I put my arm over my head before I feel the pain of the tissue damage, or whatever the respective joint motion is that correlates to the region of the damaged tissue or the injury? That is a really good indicator. And off of the backs of that, can I begin to push the envelope of my passive pain-free range of motion? Classic example, stick with the quad or stick with the hamstring. When I tore my quad, then I woke up the next morning and my thigh was black, like I had frostbite. I immediately sat down on my couch and I hobbled. It was a struggle. And this is something that I've recommended so many times over the years to people in similar situations, is I put my heel on my office chair and I begin to manually take my leg and pull my knee up into flexion and then lower it down into extension, and be like, how much passive and active knee flexion extension do I have that's pain-free? And dude, I sat there, and I'm talking like thousands of reps a day. It was just sitting there. And guess what? After the first day, I had about 5-10 degrees more pain-free passive range of motion. Like, once you've, within the medical disclaimer of if you fucking get shot, don't just fucking put your heel on a wheelie chair and start moving your leg around like it's going to be okay. But within reason and, under the flag of logic, you can work on, pushing the discomfort level towards the end of passive range of motion and really start to set the changes. And here's something, I had this conversation with someone today, actually, and I was describing to them the timeline of a chronic injury. And I think this is super useful to understand. When you ask someone, or someone proclaims I have chronic low back issues, more people than you think that you talk to have chronic low back issues. The designation of chronic as a term, as so far as it correlates to a elapsed period of time, is way less, technically speaking, than people think, right? When you hear someone says, I have chronic low back pain or I have chronic knee pain, immediately, based off of just how we've been presented with this information in the past, you're thinking like years. Chronic is anything over 2 weeks. That's chronic. So, and that accelerates your window of decision making, right? That compresses like the opportunity costs that come with getting your initial steps wrong. Because a day of starting your rehabilitation process, whatever that is a lot more valuable in a time horizon of 12 days or 13 days or 14 days than it is in a time horizon of 6 months. So when you look at chronic sets in at 14 days, I need to start gathering data very, very quickly and start to put together a plan, right? Now, your best plan might be to go talk to someone who makes plans for a living. But if you have a little bit of wherewithal, I think expediency and urgency are so understated. Now, it's a fine balance. Our first point was like, take an inventory, take a time, take some breath, take a night, take a day. But once you are experiencing symptoms that are relatively consistent, hour over hour, and it's stopped getting worse, and the pain associated with the underlying tissue damage has peaked and plateaued, now it's go time, right? Now it's an episode of 24. You got a little timer in the bottom of your life that says you got to get this thing back into shape, because a lot of people, they don't realize that chronic is 2 weeks. And the reason chronic is 2 weeks, and something that's so hard for people who aren't well versed in this, is because chronic really refers to your brain's interpretation of the injured area, way less than it has to do with the actual tissue damage itself, right? The healing process and the pain side, or the pain perception, are two very, very different things. right? And now pain science is super complex, but at the very least, I think it helps to go, okay, I have 2 weeks to get ahead of this. So if you're going to see someone, it's do not go to work in the morning. It's not like I will go on Wednesday when I drop the kids off. It's like, no. I'm calling the babysitter and I'm going ASAP because I know that I have this 14-day window. So when I were to build off of that first point of like, hey, step number one, chill. Step number two, once you've chilled and it's chilled, now it's time to develop a plan because chronic sets in and it becomes a much more difficult problem to solve if we haven't made up some serious ground in the first 2 weeks.
Yeah. Yeah, I really like that perspective. And with that, kind of off the backs of that, the way that I like to manage this stuff once you get to that window, because there is that acute window where things aren't going to necessarily present the way that makes it very clear on what the injured tissue is or the damaged tissue is, assuming there is tissue damage. Then you want to start to move forward. The way that I move forward from there is 3 words: better, worse, same. Right? Is as we start to introduce movement, and it could be in the way that you said, passive, where I'm assuming that when you're wheeling your knee in and out on the office chair, there's probably a point. It probably doesn't feel great to do that, but if you were to do that, rep 0 versus rep 10 versus rep 999, as you progress, I'm assuming it's getting better, right? Or it's not getting worse at that point. And that's the exact information that I use to govern pretty much everything in exercise, but especially when we're dealing with injury, is that we just don't want to make it worse with what we're doing, right? And that could be in a very, very acute sense or a very compressed time frame from one set to the next, or that could be from 1 week to the next or 1 month to the next. Is that we're looking at this in a way where the things that we're doing are going to at least enhance subjective sensation through that area. So if it's a herniated disc, you're probably going to hobble in to the gym. You're probably going to have a hard time moving through the same range of motion in which you injured it. So for me, I was very extension intolerant. It was an extension injury. So I had a hard time getting into that position. So I was kind of just like really fucking bent over forward. So what I would do would just be things that would allow me to get into more extension with less discomfort. And those could be very remedial things. They probably will be very remedial things at first. Like these can be just like dead bug exercise. I didn't do dead bugs because fuck that. But these can be like remedial core exercises where I'm just starting to rewire that kind of brain to muscle connection, that proprioception of I need to be able to activate these muscles, because right now there's this kind of override switch that's flipped that I'm not allowed to actively move that area or load those muscles because my brain's saying, fuck no, you're going to hurt yourself again if you move this way. So I need to slowly start to gain the trust of my brain and my nervous system in a way that's going to alleviate the symptoms that are not necessarily the injury, but they're a result of the injury. So muscle spasm and disc herniation are 2 different things, but it's not necessarily the disc herniation that's going to give you the pain. I mean, maybe in some cases, yes, but a lot of the discomfort that you're going to get from an injury like that is from muscle spasm that is protecting you from re-injuring or injuring that area worse. And similar thing with the quad injury that you mentioned, is that your brain, your nervous system is protecting you from re-injury. So what we need to do, and this scales with tissue recovery time, I need to start to regain the trust to move in that way again. But I need to do it in a way that's consistent with what my body will allow and is not going to actually re-injure. So this is the same way that we talk a lot of times about mobility, stability, strength, right? We need to be able to access range of motion before we can stabilize it, before we can load it. Cool. All right. Well, same sort of thing here is that if I can't move a certain way, then there's no way that I'm going to be able to build the capacity or gain the trust of my brain that I can stabilize that area actively. So I'm not going to get back to the point of loading it again. And that's when you hear people that like, oh yeah, I got a bad back. I herniated disc in high school, and it's 20 years later and they haven't touched a barbell, or they haven't done any sort of axial loading because of that. That's because you never got to the point where you regained the trust that you can stabilize that. So we need to put people in positions where we're challenging them in a progressive way to overcome that stimulus of protective muscle spasm. So, and like I said, that boils down to 3 words: better, worse, same. If I'm working with someone with, whether it's an acute disc injury, an acute quad tear, whether they got hit by a Suburban, it doesn't matter. I'm going to put them in positions, and I really liked what you said about going through the passive range of motion. And the next step to that would be active range of motion, right? Is we want to see what range of motion can you access actively. And that's going to give us a lot of information, because that's going to tell basically this whole process. It's going to say how much trust you have from your nervous system to move in a specific way. And active range of motion to me is assessment. Those are one and the same. Is I'm assessing you as I see how you move, and I'm overlaying that with subjective sensation, right? Is how does this look? Where are we restricted? We can build some sort of understanding of why we're restricted based off the injury. And then I also want to know subjective sensation, and that's better, worse, same. Is that if I can put you in a position and you start to feel the discomfort, say, okay, all right, I know that you have, I don't know, 15 degrees of active knee flexion before your quad starts to feel bad. Okay, I can work with that. Maybe we're going to do something, again, very low level to give you a stimulus of control in that area in a pain-free range of motion. And then I'm going to test it against active range of motion later on. So maybe we do 5 sets of 15-second isometric quad extensions at 10 degrees of knee flexion. And then I just see, okay, you were able to get into 10 degrees, start to resist some sort of force there. Now we're going to go back, and I want you to see how much can you flex that knee actively without causing pain. And then we can start to build some sort of understanding of, okay, these are the things that are going to stabilize this area, but we're doing it in a safe way where the number one thing is I'm checking in with either the client, the person I'm working with, or myself, and saying, okay, is this getting worse as I do this? If the answer is no, then it's probably not going to make the injury worse. So I'm going to go through and I'm going to do that, and then I'm going to retest, and I'm going to do that and retest. And then the demands of that piece, that isometric quad extension at 10 degrees, that's going to scale with their ability to move through pain-free range of motion over time. And that's the most simple way that I can put rehab, is that we're matching their demands, we're keeping them in safe positions, we're not increasing subjective sensation, and there's a differentiation there that has to occur. Subjective sensation of pain, right? This is going to be uncomfortable. There's going to be things that probably don't feel good as we go through this process. But if these are not the same symptoms or the same sensations that you're coming in reporting as your symptoms, then it's probably okay. Or if it's not making those symptoms worse. So that's the way that I like to think about that next step, is that, okay, all right, we understand the injury. We've given it time to chill out. Now we've gotten you to move passively. We have an understanding of what you're capable of moving through. And now let's move on to active range of motion, but let's do it through this lens of, okay, we're probably going to cause some discomfort here, but we're not going to do things that actually aggravate the symptoms, so that you're actually leaving this session feeling better than when you walked in.
I think a big thing too, because pain does become our guide through passive, active, potentially assisted, active, and active resisted,
Right.
is we're talking a lot about what to do. And I think it's worth interjecting with what not to do. A lot of people reach for the Advil or reach for the Tylenol. They reach for the ibuprofen or the acetaminophen or the Panadol, wherever, if you're in Australia. And it's like, no, no. We need that signal to be clear. And we need that to be noisy, because we need that to be a true representation. And what I have found, in dealing with soft tissue injuries that usually accommodate a decent amount of swelling, it's like, this shouldn't be news to anyone that the swelling is necessary. That's why it's happening. And I think if you're treating your rehab in the spine of your, training around your injury, it's kind of turning into a rehab thing, which I think is probably more valuable anyways. If the change maker or the thing that's really moving the needle for you, I think it should always be pain-free range of motion in whatever way we're getting that passive, active, assisted, active, or active resisted. Simultaneously, you've used the word sensation a few times, and I'm really glad you did, because I think there are interventions that are external that I think are really useful to start introducing. we want the brain to stay this malleable elastic. We don't want it to plasticize. We don't want it to start to learn this new state of experiencing the perception or the sensation of pain. When we see therapeutic modalities such as kinesio tape or theraguns or foam rollers, we have a potential opportunity to intervene and retest against our objective outcome, which is pain-free range of motion. So I am a big advocate in these times of like, let's flood this area with stimulus that gets different parts of the brain, both peripheral nervous system and central nervous system, aware of this area in a way that's different than just the perception of pain and presence of pain. However, let's adhere to our spine, the core of our progression, which will be the test and retest on passive range of motion. So let's say, for example, I do my hamstring or adductor, and I'm sitting there on the couch with the heel on the chair, and I'm pulling up and down. I might do 100 reps, and then in the time between, I might take a Theragun to what degree it's discomfort and rather than pain. And maybe it's just the surrounding tissues that are going to be compensatory. Like when you talked about the rolled ankle, you're like, everything from your TFL to your fucking toenail is going to be a problem. So I'm going to introduce this vibration. I'm going to maybe put some tape on it so I get a little bit more skin stretch as I work through what will ultimately be a shorter range of motion passively. And I think, I can do a few things: better, worse, same, right? Subjectively, hey, how does it feel? It's like, yeah, it feels good, or it's sore, but it's not bad pain. Like, okay, when I go back on the chair now and I put my heel up, does it feel better, worse, same? And more importantly, is my knee flexion increasing as a consequence? If I'm introducing some noxious stimulus that's increasing inflammation extra physiologically or decreasing inflammation extra physiologically, that is also a concern. We want to decrease in the acute stages for 72 hours and into the subacute stages. These are things where we probably want to decrease local inflammation physiologically within our physiological limits, as governed by our ability to move through pain-free range of motion, right? We will get the circulatory demands of a damaged tissue as they present itself at the edge of our threshold of pain through a particular passive, active assisted, active, or active resisted range of motion. Once you get to active resisted and you've worked through this model of like, let's test and retest against the objective outcome of the subjective interpretation of your passive or active assisted, active, or active resisted pain-free range of motion, what each one of those is going to afford you is the amount of circulation to the area that is warranted for you to mitigate the local inflammation that's there, because you don't want to get rid of it right away. You want that cytokine process, all the C-reactive protein, creatine kinase, whatever is present in damaged muscle tissue, to do what it's meant to do. But you want that to be a beacon that goes out to be like, hey, blood here, get your blood. We need blood here, please. Thank you. And I think trying to skip the cue is very misguided. Now, look, internal ways of driving down inflammation chronically over time are great. Peptides are really big in the space. Sometimes anti-inflammatories are called for. And, if you're dealing in a situation where you're just a lifter that doesn't have the Super Bowl tomorrow, we're sticking within a range of normal presentations and normal situations. But I would say people are way too quick in the first 2 weeks. I am not introducing any sort of medical assistance on my thing that's mitigating my inflammation is my own circulatory system, which is being called on my constantly pushing my passive pain-free range of motion until it's full, and then following up with active assisted pain-free range of motion as I make the step from passive to active assisted to active resisted. Each one of those little progressions is going to carry with it an increased demand on the muscle, which is going to mean an increased demand on the circulatory system, which as I begin to activate, an increased demand on the lymphatic system. So I'm internally buffering to the degree by which I'm probably going to need to disperse and shuttle out that inflammation. And it's completely mediated by my sensory response to my range of motion. If my sensory response is that, hey, it hurts here, and even after doing, passive range of motion, I only get an extra 5 degrees. It's like, oh, the swelling's still really bad. It's like, yeah, good. Good. Let's keep the swelling in there. And then as we go through more passive range of motion, maybe we introduce some of these therapeutic tools that send a stimulus to the brain that helps localize mechanically where this sensation is being perceived that is in pain. As we start to pick up more range of motion, we're going to get more circulation. And that more circulation is going to be an indication that the brain is ready. Neurovascular bundles. Whenever you see a major blood supply in the body, you are seeing a major nerve run along with it. It is very rare that you find these things running separate from one another. Why? Because nerves need blood to stay alive, right? And they need a turnover of blood, right? But if we're regenerating tissues, these signals that are keeping blood in the area are useful, and the pain that's associated with that is useful. And I think a lot of people are so quick to try and get rid of inflammation. Inflammation is bad. Oh, inflammation, it's cause of all the metabolic disorders and all this stuff. And it's like, yeah, but like, look, it's complicated, right? Like it's your body. So I think that's something where as we build this framework of like, hey, chill a minute and then get to work. Your work looks like passive, active assisted, active resisted. And we're looking for that pain-free threshold that might exist somewhere in discomfort. Maybe we intervene with other stimulus. I'd say do not, again, not medical advice, I would stick away from anything endogenous that helps, so outside the body, that might help or claim to help against managing some of that inflammation, because your inflammation will be managed by your ability to start to progress through movement. And once you get to active assisted range of motion, the blood supply demands to that region will be so that this inflammation will subside in kind.
Whew,
That
that's
was a long sentence. That was a lot, dog.
Was that all one sentence? Damn.
Yeah, I'm gonna chat GPT that.
Yeah.
Fix that for me.
Sick. Yeah, I love it. And this is kind of turning into a little bit of a rehab bias conversation, but the way that we can start to bridge that gap back into training is that I like to move forward with this idea that you're going to learn a compensation pattern after an injury, right? Especially in the ones that we mentioned, the quad, whether it's hamstring, the disc herniation I had, is you're going to learn a way to do life around that injury, right? And you kind of have to keep doing life if you want to stay alive to train. So your body's going to find a way to make that happen, but it's not going to be the same way that would be the most biomechanically sound way to carry out the exercises that you want to do, whether that's a leg press or a squat or a walking lunge or whatever it might be. So there's going to be this period of time where the way that you start to move is to protect your body from re-injuring or to aggravate symptoms. And that's not going to be consistent with symmetry in most cases. So there's going to be a period of time where that starts to feel normal to you, the way that you're moving. So your body adapts, and now what you perceive to be normal movement is a compensation pattern. So as you start to get back into training, as you get through this kind of better, worse, same progression to the point where, okay, I'm ready to start loading these tissues again, I think two things need to be understood. First is that unilateral work needs to be done before bilateral work. It's going to be more important so that you can start to understand, even if it's just to build awareness around the compensation pattern or the deficits in specific tissue that have developed from that compensation pattern. And the most important thing is I boil it down to the word awareness. You need to become aware that the way that you may be moving, the way that you perceive to be moving normally, the way that feels right to you is probably not, right? It's probably a compensation pattern. So when you start to build that awareness back towards symmetry, back towards more advantageous biomechanical patterns, it's going to feel wrong or it's going to feel abnormal. So there needs to be this understanding to not necessarily trust the sensations, and it's almost more of an objective feedback that you need as opposed to the subjective feedback. Because what you are doing, say we get into we get you back to the point where you can now do a stationary lunge, whether it's supported, whether it's not. The side that you tore your quad tendon on is going to feel way different than the side that you didn't. And probably in both foot orientations, there's going to be a compensation pattern, right? It's I wasn't going to do it, but I'll go into it. But like as you become more weight bearing on one side, you're going to basically rotate your body towards that side, right? There's going to be a compensation through all three planes where you're probably going to start to bias, through the lower body. I'd imagine that the weight bearing side started to bias more of a posterior pelvic tilt, which is going to set a trajectory towards abduction and external rotation downstream at the foot. Versus the side that you're less weight bearing, there's probably more of an anterior pelvic tilt, and it's probably going to be biased more towards extension and adduction in that side. So, like, simply put, if you guys are watching this, your feet kind of look like this as you're standing upright, and that's what feels normal. So as you get into a lunge, you're going to start to bias through all three planes the way that feels the most right to you. So we need to have this kind of conscious override of, all right, I know this is what feels right, but I need to be aware enough to understand that I'm trying to get to adapt back towards a symmetrical position. So that might mean that on your non-weight bearing side, you need to force more of an externally rotated abducted position. On your weight bearing side, maybe you need to force more of an adducted internally rotated position. And of course, doing things that are consistent with this. I won't go down the rabbit hole of the specifics of that, but doing things that are going to allow you to create more symmetrical core tension. So like I said, you're going to rotate towards that weight bearing side. So understanding that you need to now use your core to create a more symmetrical pelvic position so that you can properly advantage the muscles that have been at a deficit for so long. And it's going to be uncomfortable. It's not going to feel right. And that's why you can't purely rely on subjective sensation in that phase of training, is that you need a mirror, you need to take video, you need someone watching you so that you can understand the pattern that you're going to bias and the pattern that you need to move towards, and start to build this understanding of, okay, it feels good when I do it this way, but it looks wrong. And it feels bad when I do it this way, but it looks right. And probably what you need to bias is the thing that feels bad and looks right as you start to get back into more normal training. So that's the awareness piece becomes really important as you get back into training after an injury, because you can't necessarily rely on what feels good, because what feels good is going to be the way that you've been moving for, I don't know, a quad tendon, herniated disc. We're talking like months. We're talking 2, 3, 4 or more months, depending on the severity of the injury. So that's a lot of time for you to build this perception of symmetry around asymmetrical movement.
Yeah, and I think stemming off the awareness and maybe like bringing it full circle is like, okay, now it's time to look back. And as you pick a few movements that are looking to unwind some of the compensations, how did you get here? Right? How did we get to this place where, we had to have gone through this step-by-step process to let's chill out a bit. Let's go through, passive active, assisted active, and active resisted range of motion, reestablishing the integrity at both the joint and the muscle, and then looking more globally at reinstating integrity through the system. And then, you create this awareness around, I know it feels off, but I'm working my way back to what would be objectively normal. It's like, okay, what have we learned? Right? What have, and I think that piece gets missed a lot. Was it a programming issue? And look, injuries are so multifaceted and they're almost impossible to predict, but it doesn't mean, and like the thing is, over time, if you run into enough walls, you can start to terraform weight training for yourself, given your lifestyle, given your recoverability, given the constraints of, around your ability to train, or, some people just are full send it people, and it's every day. It's like, yeah, you train 3 times a week, always. Because when you go in, you're trying to kill yourself. So it's like, what have you learned that you can take away from this process and bring into the future? Like, if you look at your same workout split and you go, all right, let's run it back, like same volume, same exercises, shooting at the same load. It's like, start there. And it doesn't have to be like, these massive tectonic plates that shift underneath your program, but respect the fact that these things probably had a compounding effect to have put you through this. Over time, the goal should be to have less severe injuries less often, that you get over quicker. And if you follow this process right, and you have to do the last step because you're setting yourself up for re-injury or potentially taking a paradigm of training and just applying it to the next less resilient tissue in your body. And you just end up with a, somewhat of a conveyor belt of, higher magnitude, more costly injuries. And you could tell that this process works is if over time, the magnitude of the injury decreases, the amount of downtime in between getting back to full decreases, and you just end up a little bit, you end up a little bit more resilient by like, oh, wow, okay, I neglected that in my program, or that tissue wasn't strong enough, or I was overloading that too much, that you begin to start to kind of fix the problem from both ends, right? So you fix the problem from, the idea that you're applying chronic load to it, and you also fix the problem from the side of like, hey, I have a little bit of variability now that I've gone through and I've worked through some of these compensations that have existed. And I think that piece is so huge that oftentimes gets skipped over. It's like we kind of look at this like, I feel better now, and then I go back to my dumb shit. It's like, no, please. Like that awareness, I think, is such a good catalyst to it. Like, I still notice the difference in my right shoulder when I do pull-ups because I'm missing part of my pec. Right. I still notice a difference in lunges, and I'm aware of it. And it's almost like, when I reach for, I don't know, like when I have weight loss clients reach for BCAAs instead of a full sugar Coke. It's like, it's a little bit of a reminder that like, hey, you're going to make healthier decisions now. Right. So when I do pull-ups every week, because I'm like, it stops me from, when I see half of my arm up in the air and I'm pulling it back in towards my body going, oh, that shouldn't be there. It's a reminder of like, yeah, we've made some mistakes, and let's not continue to make those mistakes. Right. So like, I don't think in my lifetime I have any aspirations to bench 440 pounds again. And it's pull-ups every day, or, when I see them in my program, that are the reminder of that, because I need to be consistently aware. So as you're gathering that data and you become more aware and more sensitive of your position in space, apply it, take that information, let that be sort of, you're like, oh, wow, I'm still like pretty fucked up. Oh man, remember that time I fucked myself up? Yeah, that was fucked up. All right, my next exercise is going to be the less stupid option this time. Right. So I think like to kind of bring it full circle, that's where you cyclically become more resilient in weight training, is by taking that awareness piece and then, acting that into the future and really learning from what got you, and that to the best ability you can. And look, here's the thing. Injuries are hard to predict, but if you have an awareness around your training and you do this process with every injury you have for, I don't know, coming on 20 years now, you're going to get pretty good. And you'll learn to enjoy weight training. And when you run into problems, they will be fun things for you to solve, albeit annoying, but you'll still have the essence of being able to go into the gym and do the thing you love. Like, I thought I was going to need bilateral knee surgery last August. Like, I couldn't bend my knee. I couldn't walk upstairs. I couldn't walk downstairs. I couldn't walk. I couldn't lay down. Everything hurt. And I was like, okay, let's do this. Let's fucking take this on. Right. My back was killing me 3 or 4 months ago. I was like, all right, I'm going to make a change. I'm going to do something about this. And then I'm like, the periodized exercise. What have I learned? And a lot of it was I stopped doing things. Yeah. I stopped doing things. I stopped squatting. I stopped deadlifting. I stopped doing hinges. I stopped doing bent over rows. So it's like, I just took an inventory. And it's so funny. Like, I went in and worked out the other day, and it was so full circle. It was like deadlifts, pull-ups, single arm dumbbell rows. And what was the last thing I did? Oh, pronated grip lat pull down. That was my pull session. And those are the things that I feel really good at doing with all my injuries, with my torn quad and my fucked up right ankle and my no ACLs and my meniscus that are shot and my AC joint that's separated and my rotator cuff that's torn and my bicep tendon that's torn and my pec tendon that's torn. And that session is like, so I probably was I read that in a magazine when I was, I don't know, 15. And yeah, a magazine, for those of you listening, is this thing that used to just show up, and it was like a book, like comic book, but with stuff, and you could buy steroids in the back. Shout out Blackstone Labs. But it's like, and now that's what makes me feel good. And I keep those in. It's like, I have done this with every major injury and pain that I've had. It's like, what are the exercises? What was I not doing last training cycle? I wasn't doing lunges. Lunges, single arm rows, bent over rowing, hinging, squatting, pronated grip, pull-ups, dips. These are things that keep me in check. And then there are things that when I remove them, things go wrong. And now I just left with like every exercise program I write, and I just wrote a new one for myself the other day. I look at like, I just pick the exercises that make me feel good. And like, lo and behold, there are these, we're not playing with strength curves, resistance profiles. If anything, we're kind of flying in the face of that logic where, it's more compound, it's more free weight. We're not getting cute with it. We're not really supporting externally. And that system seems to, with where I'm at, work really well for me. And that was born of going through every fucking training, fad, trend, exercise, whatever. And I'm back on the other side going, all right, I had it the whole time, which is like, of course, that's how life goes.
Yeah, absolutely. And just to kind of reiterate that, and kind of the other side of that point is not just looking retroactively to think of the things you weren't doing or the things that may have accumulated to the point that led to this injury, is it also understanding proactively that once there's tissue damage, depending on the degree of that damage, your structure is not the same. Right. So there are going to be things that aren't just, it's not just a rehab piece. It's now something like you were saying, it needs to be there. It needs to be a staple in the exercise program if you want to be able to continue and do the things that you want to do. Like very similarly to you, is that I have a fucked up labrum, dude. My right labrum is fucked. Like some days I can pick up a 35-pound dumbbell and it feels like my arm's just going to fall off my body. So there's things like pull-ups have to be in my program. They just fucking have to be there. And like lateral raises, like rear delt or like upper back rows, like need to be in my program for me to be able to continue to do the things that I want to do, which is like dumb shit, put as much weight over my head. But if I want to continue to do that with two arms, then I need to have these things in my program because I understand that the structure's just not there to support what I want to do. So I need to make sure that there's no lack of musculature or muscular stability through that area. And that's a forever thing. That's never going to change. That labrum's never going to grow back. I'm not going to get surgery until my arm does fall off my body. So I just need to make sure that I'm diligent in doing these things. And I need to also accept that if I'm not doing these things, like my arm could fall the fuck off my body as I'm doing the other things. So that's an important part of this process too, is not just looking retroactively, all right, what dumb shit was I doing? I'm not going to do that. But also looking proactively, what do I need to continue to do to maintain the level of function that I want to continue to have?
Yeah, no, I like it. And I think if you follow those steps, and again, within reason, I think they're all equally as important. Some I think it exists on a spectrum of technical and tactical, right? Like technical side of like, hey, first couple of weeks, like let's really get a move on this thing. Let the dust settle. Let me see where you're at, and let's start moving it to what degree we can, and start pushing the envelope, knowing the difference between pain and discomfort, and then really creating that awareness out of the other side of it that it helps to inform better decisions by taking a look at how did you get here and where are we going. So it's common sense, but it's hard, man. Like I'm always my worst patient because like I freak out and I love training and I'm like, oh fuck, like should I just jump? Like, is this it for me? And it's like, well, okay. Like, and we know a lot of shit. Maybe, I don't know. I think I do. I've read a lot of shit and I've done a lot of shit. So it's just like, I think it's useful to have a framework where if you're injured and you want to get back to training, it's like bucket your approach into these 4 steps. And I think you're going to be in a really good spot.
Yeah, absolutely agree.
Dope. Well, we did it. Another one. Episode 5 million RX Radio. To reiterate from the intro, PSL1, we talk a lot about load management. We talk about, concurrent pain management in exercise training. If you want to get on the list, 16-week applied biomechanics functional anatomy course up now. Registration list is the only discount we do. So if you go to our website, www.pre-script.com, hit the PSL1 red box there on the top right of the website. Put your email down, and you'll get a discount when registration opens. Only in a handful of weeks now. So really excited about that. Jay, anything else before we close off?
That's it. Appreciate you guys for listening.
See you next week.